Welcome back to Coffee Talk 2, where we'll continue to unravel some more mysteries about collaborative dental hygiene practice in community settings. Last time we pointed out several nuances of the collaborative practice model that are not really clearly defined in law. So let's tackle a few of those questions that I have listed, like how to get started, what is required, supervision, and scope of practice. And how to get started is one of the big things that people want to know. In many cases, a collaborative practice starts with an innovative idea by either a dental hygienist or a dentist who identify a need for expansion of oral health care services in their community. Some collaborative practices are initiated by requests from a community, a healthcare facility, or even a school administrator. The Minnesota Dental Hygienists Association and the Minnesota Dental Association are working very hard to educate their members to participate in oral health care delivery to underserved populations in non-traditional settings. And I think that's going to be really helpful. We believe that the way to start the conversation is easier if a dental hygienist already has a good working relationship with a dentist, or perhaps the two persons are maybe just acquainted with each other from the community. One thing that's important to know, though, is that the collaborative dentist does not need to be a current employer of the dental hygienist. And after identifying a partnership, that's when a written collaborative agreement must be developed, specifying a number of conditions.
And I think we spoke to that earlier when we met. I mentioned some of the protocols that should be in place. But whatever needs to be put in there can be decided by both the dentist and dental hygienist in order to make the practice flow as they want to see it. But the law requires certain protocols to be included. Some of the major provisions are there has to be a protocol for the medically compromised patient, which is not defined. So that maybe needs to be defined as well by the dentist and the dental hygienist. Age and procedure specific protocols have to be in place, whether we're talking about risk assessment and frequency of services or whatever, could also be included in that written agreement. The consent is very important and of course needs to be kept on file, as well as a referral for treatment that can't be done by the dental hygienist in that practice setting. And another thing that I find that should be included is where those practice settings are located. The hygienist I worked with, who had a collaborative practice agreement, worked in about 10 different settings. And we actually listed those in the collaborative agreement, which again I would recommend. But for additional help, there's a template available on the website we mentioned earlier, the 21st Century Dental Team website. And again, other dental hygienists may have collaborative practice agreements that they could share, which would also be helpful. And then there's a matter of the Board of Dentistry, and there's a mandate that if the Board of Dentistry asks for that collaborative agreement, it should be made available to the board. But at this time, it's not mandated that the Board of Dentistry needs to see it unless they ask for it. However, I think in the future we can look forward to seeing questions on our relicensure forms when we sign up online, asking us questions about whether or not we are participating in a collaborative practice agreement. And this data will be very valuable moving forward in the future, so we encourage viewers and all dental hygienists to answer those questions appropriately. So that's some of the protocols that need to be included.
That's a really good start. And it's also important that we note that each collaborative agreement will be unique to each situation. There could be several practice locations, as you mentioned about the former coworker that you had, with a specific set of services offered and special protocols listed. For example, the law allows a dental hygienist to provide dental sealants in community settings. From this, we infer that dental hygienists may select the teeth to be sealed, and the law does require a protocol for sealant placement, but most importantly, the law requires a protocol for follow-up care to assess sealant efficacy. The collaborative agreement could also contain other protocols, for example, for the provision of x-rays, the provision of local anesthesia, or perhaps more new to our profession is silver diamine fluoride. But again, that's if the dentist and the dental hygienist choose to talk about those protocols.
And that brings up more information on scope of practice. Since 2001, there have been several duties that have been added to collaborative practice, and that all can be found on the website as well. I can think of two major ones: sealants, to be determined by the dental hygienist, as well as local anesthesia and nitrous oxide, which were much needed in those settings where a dentist is not on site. In 2017, the law was changed again to include all of the duties that any hygienist can do under general supervision to be included for collaborative practice. So that was a major win at the legislature. However, the dentist gets to decide how many of those duties can be performed by that dental hygienist. So that dentist could say all of the duties under general supervision are included in this written agreement, or just some are included, depending on the population they serve, the setting, and other factors. School-based sealants program is an example of this, where they may be just performing sealants or maybe fluoride treatments and assessments. So there are just some differences among collaborative practices.
Speaking of supervision, supervision of the dental hygienist involves, in this model, is similar to general supervision in a traditional dental office, where the dentist authorizes the procedures but doesn't have to be present when those services are being carried out. In a collaborative practice setting, the dentist usually is not on the premises and does not personally authorize the services, but uses protocols specifically outlined for the agreement to guide the dental hygienist. And that supervision is really at the heart of collaborative dental hygiene practice and allows more services to be provided to patients and clients and the public when a dentist cannot be present.
You make a very important point. It is at the heart of the model, and it wouldn't be successful if we didn't have that in place. Another thing that I should mention is the need for a referral system, which is very imperative. We all know that a dental hygienist can provide all the services a patient might need, and follow-up care is very necessary. As well, the law mandates that the patient be seen for an examination, but it does not say what that interval would be between the services provided by the dental hygienist and the examination. But every effort should be made to provide that patient with a referral system that's a viable opportunity for them to really complete all of their treatment. The team needs to be diligent in seeing that this need is met. Very important.
That really is the bottom line, because collaborative practice is just an excellent entry point for patients to get access to dental hygiene services that they may not have received before. And it really does take a team to make all of that happen. So Jean, let's get together again to talk about collaborative dental hygiene practice in community settings. In particular, I think we should talk further about the financial aspect, because that is on the minds of a lot of people who are considering this practice model. So here's to next time. Cheers.
Cheers.